Hey, what's up guys? My name is Jin, and in today's video we're going to go over CSCS chapter 22. This chapter is on rehabilitation and reconditioning. I'm especially excited for this chapter because I'm a physical therapist. That's what I primarily do. And so let's dive right in. We're going to take a look at sports med team here. So quickly glance over who makes up the sports med teams: team physician, athletic trainer, physical therapist, strength and conditioning professional, exercise physiologist, nutritionist, counselor, psychologist, and psychiatrist, right? Something to look at real quick. And let's take a closer look at macro trauma versus micro trauma. So macro trauma is a specific or a sudden overload injury that causes a contusion or a fracture, for example. So looking at the joint trauma here, dislocation could happen, right? It's a complete displacement of joint surface, or subluxation, partial displacement of joint surface. So dislocation is more of a fracture, right? Versus subluxation is a partial displacement from the surface there. And so taking a look at sprain versus strain here, ligaments usually get sprained and then muscles tend to get strained, right? So ligament sprains, there's first degree, second degree, and third degree. First degree sprain is a partial tear of the ligament without increased joint instability. So there's a little bit of a tear and then not too much of an instability. That's the first degree. The second degree, now there's a minor instability and then it's still a partial tear. And then a third degree ligament sprain is a full tear with full instability. Looking at muscle strain, there's direct strains, we call that a contusion, and then there's indirect strains, and we just call that strains. So there's 3 degrees here as well. The first degree is partial tear, but you can still activate that muscle, it's still strong, and there's a little bit of pain, right? With the first degree. So first degree, strong but painful. Second degree, weak and painful, right? So now the muscle's gotten a little weaker. You're still feeling that pain. That's second degree muscle strain. And then third degree is weak and now there's no pain, right? It's because it's a complete tear of that muscle. So read over that. And then microtrauma is an overuse injury. So if macrotrauma is caused by something very specific and stressful, that's overloading the tendon. Microtrauma is because of that repetitive overuse. And so things like training errors, suboptimal training surfaces, faulty biomechanics, insufficient motor control that overload one tendon or a muscle tends to cause microtrauma. So if it's at the bone, stress fractures are things that could happen because of that rapid increase in training volume. You tend to see some of these stress fractures in youth athletes in their bones. And then if it's in the tendon, you can get tendonitis or inflammation of a tendon. So things like tennis elbow, for example, where the elbow gets inflamed because of the tendon that attaches to the elbow. That's because of that repetitive overuse. So moving on to tissue healing. So there's 3 phases here: inflammatory response phase, which is the first phase, fibroblastic repair phase, which is the second phase, and then the maturation remodeling phase. And that is the last phase there. So taking a look at the first phase, the inflammation happens, right? That's the initial reaction to the injury. And then you can see some local and systemic inflammation. You might see some swelling, you might see some bruises locally. And then systemically, they want to try to bring a lot of blood to the area so they can bring chemical mediators and increase the blood flow to the area so the tissue can heal faster, right? So locally it may be hypoxic, which means there's not a lot of oxygen there, but systemically you want to try to pull everything in there so it can heal. The second phase here is the fibroblastic repair phase. catabolism and replacement of tissues that are no longer viable. Don't know if you guys remember from earlier in the book, but catabolism, you're breaking things down and then replacing them. And then in that spot where everything's kind of broken down, type 3 collagen gets deposited. And then finally, the maturation remodeling phase, type 1 collagen gets deposited. So let's take a look at this graph here. You still see that inflammatory response phase in the beginning, fibroblastic repair phase, and then maturation remodeling phase at the end. Pain's going to be very acute, and you're going to feel a lot of pain in the beginning. And as we get into that healing fibroblastic repair phase, where type 3 collagens get deposited, the pain's slowly going to go down, right? And then tissue healing, of course, is going to be opposite of that. It's going to take some time for the tissue to heal. And then adequate tissue healing threshold, it's important to know when to safely resume full activity, and that's the sweet spot that we want to target at maturation remodeling phase. We don't want to go return to full activity too soon or too late. All right, moving on to the next slide here. Things to keep in mind. Healing tissue must not be overstressed. So it kind of goes hand in hand with what I was just saying about not overstressing a healing tissue too soon. And then here also same thing, athlete must meet specific objectives to progress from one phase to another. And this is what we do in physical therapy essentially, is we provide you some guidance and safe milestones that are structured for you to achieve success long term. So there are 3 steps that we just talked about, 3 phases. Inflammatory response phase. In this phase, you want to try to prevent disruption of new tissue, right? And so because it's still healing, you're concerned more about safety. So treatment goal here is relative rest, physical agents, icing it, compression, elevation, resting it. That's going to be important there. Max protection of the area, like I said, safety is number 1 at this stage. So wearing something like a boot or a cast might be necessary. General aerobic and aerobic training. And then exercise strategy is, like I said, passive rest. Moving on to the fibroblastic repair phase. Now the treatment goal becomes a little more complicated, right? So you want to try to prevent excessive muscle atrophy because we don't want the athlete to return to their sport too late. So appropriate exercises is going to be important here. And you also want to try and keep the joint from deteriorating too much because what's not used gets atrophied. Low load stress gradually introduced. So at this point, you want to still try to avoid active resistance exercises, and you're slowly reintroducing that low load exercises for the athlete or your patient. So with exercises, isometric is a good place to start once you're in this phase of the fibroblastic repair phase. There are several research out there that shows that isometric exercises do have some analgesic effects around a joint. And so that's a very safe place to start. And then moving on to eccentric exercises where you're lengthening the muscle and producing force, so greater force production and less energy expenditure compared to concentric exercises there. And also very important in this phase, neuromuscular control, so ability of muscles to respond to afferent sensor info, reteaching and relearning how to respond to stimulus with muscles. This phase is going to be important as well, so that could help with some of the joint stability as well. And then finally, the last phase is fibroblastic repair phase, and this is when we get into return to sport testing and seeing how the athlete does compared to how they were before, maybe if you have that data. but we want to try to simulate the environment that they're going to go into as best as possible. And so the treatment goal here is progressive tissue loading, and of course that's going to result in improved collagen fiber alignment and fiber hypertrophy. And with exercises, a couple of different things here. Joint angle specific training, so training and prescribing exercises in certain joint angles that's functional for the athlete is going to be crucial here. Velocity specific muscle activity, are we focusing more on decelerating, accelerating? Where are their deficits? How can we prevent re-injury is going to be fundamental in thinking about velocity specific exercises there. Closed chain exercises and sport specific activities at this phase. So that is it for this chapter. It's a very short chapter. I hope that was helpful. If you guys have any questions, let me know in the comment section down below, and I'll be happy to talk to you guys. Thank you, and have a good day. Bye.
All right, welcome back. This week, moving on to Chapter 22, Rehabilitation and Reconditioning. We're in the home stretch now, so after this chapter, there's only 2 left. There's one on facility design, and then another one on legal issues and policies and all that kind of stuff. So almost done. With respect to rehab and reconditioning, if you're working as a strength and conditioning coach or strength and conditioning professional, as they always say in this textbook, one of the things that you're going to do is to probably work closely with the athletic trainer from a rehab standpoint. So you're not, going to be on your own doing rehab, but typically it is after the athlete is pretty close to being ready to return to play, then they're going to start working with you, and they're going to be doing more of their sport-specific drills by the time they get to you. So as a strength and conditioning coach, you're probably not going to work with athletes early in the rehab. That's going to be mostly the athletic trainer and or the physical therapist. And then, like I said, once they get to you as the strength and conditioning coach, it's going to be pretty close to their time to return to play. And so you're going to be doing a lot of really sport-specific stuff with them. But nonetheless, this chapter kind of gets into some of the details about tissue healing, goes into great detail about the various members of the sports medicine team, and then has some specific terminology that you want to be familiar with, things like open and closed kinetic chain exercises. So in terms of the overarching principles of rehab and reconditioning, the first thing there is that the healing tissues must not be overstressed. So after an injury, we'll talk about the different phases of tissue repair, but in that second phase, like right after the acute inflammatory response, you're into a fibroblastic repair phase where the fibroblasts, which are the immature connective tissue cells. So remember, thinking back to 201 and 202, blasts are immature cells. So fibroblasts are immature connective tissue cells, similar to osteoblasts in bone or chondroblasts in cartilage. All of those blast cells lay down a lot of the extracellular matrix, and all of them generate lots of collagen. So in the case of fibroblasts, those are cells found in connective tissue like the loose areolar tissue, or they're found in tendons and in ligaments. And so those are going to be the cells that generate the collagen. So after an initial injury, typically starting about 3 days after the initial injury, those fibroblasts, their production of collagen is going to really ramp up. But the type of collagen that they produce is a type of collagen that is not especially strong. It's type 3 collagen. And so one of the ideas there is that even though the inflammatory process has subsided, so their swelling has largely gone away, the injured area is not all red and painful anymore, we don't want to go nuts and overstress that collagen that's not very strong and that's not really aligned along the lines of stress of the injury, because potentially we could re-injure them, right? And so that's one of the overarching principles, is the idea that we don't want to apply too much stress too soon and thus exacerbate or worsen the injury. The second thing on there is that the athlete has to fulfill specific criteria to progress from one phase to another. So a lot of what we do from a rehab standpoint is the athlete has to check certain boxes to move on to the next phase of their rehab. So for example, I wouldn't have an athlete do balance exercises before they had a certain amount of strength. Let's say, my go-to example for this whole talk is going to be if somebody has a lateral ankle sprain, which is your typical inversion ankle sprain. So let's say somebody sprained their ankle. Before I put them on an AirX pad, which is like that blue squishy pad, and have them do a bunch of balance stuff, I have to make sure that they have good strength around the ankle. So I'm going to spend a lot of time before that doing things like using TheraBands or special rubber bands to have them go through different ankle range of motion exercises and resisted exercises. And once they have sufficient strength, that's my criteria here, then I'm going to have them do proprioceptive or balance stuff. And then once they're good at both of those things, now I'm going to have them do maybe some plyometric stuff where we have them do some hops and those kinds of things. But they can't obviously do one-legged hops if they don't have balance and they don't have strength. And so that's kind of the process of rehab, is once they've checked certain boxes, once the swelling has subsided, once the inflammation has subsided, now we can do isometric strengthening, then we can do isotonic strengthening, and then we can do balance, etc. So that's kind of the general process for how things work. So the program has to be based on science and all of that stuff. In reading that, one of the things that came to mind is that you're seeing things like ice kind of fall out of favor. So, if your experience as an athlete was anything like mine, it was anytime you get injured, put ice on it, right? And that's not necessarily wrong, but one of the things that ice does is to probably cause vasoconstriction, causes blood vessels to close down, and limits swelling. And so the idea there was that if we could limit swelling, then we could limit pain, and then we could have them start doing range of motion exercises and start being active a little bit earlier. But the more contemporary school of thought is basically that you don't want to do a bunch of things that tamp down inflammation. So you don't want to give them a bunch of anti-inflammatories like ibuprofen, for example, and do a bunch of ice and stuff, because then that's going to interfere with the inflammatory process, and the inflammatory process is actually an important part of healing. So we don't want to do a bunch of stuff to tamp that down, because potentially that's actually going to lengthen the rehab process. So while athletic trainers and physical therapists do still use cryotherapy, aka ice, there's other cryotherapy techniques, but basically anything that causes cooling, it falls into cryotherapy. So while everybody still does use ice some, the primary reason that people use it now is to reduce pain, to allow for range of motion exercises and those kinds of things. So people don't do as much icing as they used to. So like before, and this is 10, 15 years ago, really aggressive icing would be like you ice for 20 minutes, take off for an hour, ice for 20 minutes, take off for an hour, and then you just do that for the first, give or take 3 days after the injury to really work to minimize that swelling. And so people don't really do that as much anymore. They'll basically do some icing to minimize the pain, to allow for range of motion, and then the range of motion itself should help to minimize the swelling, which hopefully then reduces pain. In terms of team-oriented approach, that's what the next several slides are about all the members of the sports medicine team. Now, one of the things I would point out is that if you're at a big university, so if you're at Madison, if you're at Michigan, Notre Dame, etc., you'll have all these members of the sports medicine team, but if you're not, you probably won't have all of them, and you may only have like 2 of them. So we'll go through those. So one of the things is that all the members of the team obviously have to be able to work together. They got to communicate well to ensure that the athlete recovers from the injury and that they're ready to return to play. And hopefully when they return to play, they'll be pretty close to their pre-injury level of performance. So the first member of the sports medicine team is the team physician. So the athletic trainer usually works under the team physician. Like they, in some states, have to practice under the license of a team physician. So what they do then is, like, let's say, again, to use my example, they have an athlete who has a lateral ankle sprain. One of the things that the athletic trainer will do is to say, okay, I think this athlete sustained a grade 1 lateral ankle sprain. And they'll tell the team physician, they'll tell the coach, and then in telling the team physician, the physician will go, okay, great, you handle it. Or they'll say, I don't know, that maybe that's a little bit more severe than a grade 1. Maybe that's something I should take a look at. Why don't you, bring them into the office, and then we'll do some x-rays, or why don't we make sure that I take a look at them the next time I'm on campus, those kinds of things. So the team physician is the one who has the biggest say in how injuries are handled. Also in referrals. So like I said, everybody kind of works under the team physician to a large extent. The athletic trainer does most of the day-to-day stuff. So the athletic trainer will usually do the initial injury evaluation, oftentimes determine or play a role in determining the need for referral. Does this athlete need to go see an orthopedist? Do they need to go see a gastroenterologist, depending on what they got going on? Those kinds of things. So most of the rehab is going to be handled by the athletic trainer at most places. Now, at some places, like bigger schools, like in professional sports, you'll have individuals that are dual credentialed. They'll be both an athletic trainer and a physical therapist. If you don't, typically the more intensive rehab is handled by the physical therapist. So, if you're working at a high school and you do have an athletic trainer, but you have an athlete that is recovering from an ACL tear. So let's say they tore their ACL and then they had surgery. Most of the early phase of that rehab is going to be handled by a physical therapist, typically in an outpatient clinic, and then the rehab gets transferred more to the athletic trainer. The athletic trainer is going to do some stuff with them early on, but usually there's essentially a handoff from the PT to the athletic trainer, and then they'll make their way, like I said, when they get close to return to play, they'll make their way to the strength and conditioning coach. So typically PTs handle the most intensive part of the rehab, like the early post-surgery kind of stuff is usually the PT. Strength and conditioning professional, really long stuff there, but the idea, so strength and conditioning professional or coach does performance enhancement programs, so trying to make the athlete bigger, faster, stronger, more powerful, all those kinds of things. But strength and conditioning coaches also do prehab, so their program, let's say for a soccer team, may include a lot of like plyometrics and landing exercises and lateral hip strengthening and core strengthening to try to minimize the risk of ACL injuries. So strength and conditioning professionals can play a really important role in prehab or injury prevention as well. Physiologists you're not going to have unless you're at a big school, but the physiologist will kind of assist but they'll work with the athletic trainer, they'll work with a physical therapist to ensure that the athletes, usually they do a lot more of the cardiovascular stuff, but that the athlete's conditioning is sufficient to return to play. Nutritionists or dietitians, they're going to handle the meal planning, if you will, and again at a bigger school. But so big schools like Madison, like Michigan, etc., will have dietitians on staff, and so the athlete will work with them to maybe gain weight, to maybe lose weight, and then post surgery or post injury. Sometimes the dietitians will put them on like anti-inflammatory type diets, where they'll have them do a lot of things like a lot of antioxidant-rich foods, a lot of things like green tea, turmeric, all kinds of different stuff. And so the dietitian will be the one who makes that, or who makes those recommendations. The psychologist or the psychiatrist, so typically team psychologists from a rehab standpoint will work with athletes on like fear minimization. So if you had an athlete who had injured themselves, let's say you got a gymnast who fell off the beam and had injured themselves, one of the things that the psychologist will do is to, maybe they've got some anxiety related to that when they go back out and try to perform. So the psychologist will work on helping them to overcome that anxiety associated with that particular traumatic event that they fell off the beam and injured themselves. Same kind of thing, like there's a saying in sports medicine sometimes that it takes a year to physically recover from an ACL tear, but 2 years to mentally recover. And so that's another thing that the psychologist will work with them on. And so you'll see athletes, even though they've been cleared, sometimes shortly after an ACL tear, they'll go and they'll be really hesitant to cut. They won't put a lot of weight on that leg, like during actual gameplay. And so the psychologist will work with them on that of ensuring that they're comfortable performing the things that they need to do for their sport. So things on here. So there's a couple of important terms here, indications and contraindications. So I usually start with contraindications. Contraindications are things that you're not supposed to do. So for example, if somebody is immediately post-injury, they sprained their ankle yesterday, resistive exercise would be contraindicated. It'd be something you're not supposed to do. So if they just sprained their ankle yesterday, you don't want to put a TheraBand on their ankle and have them do a bunch of resisted exercises, because that's actually going to make the injury worse, right? So it's contraindicated in that case. If you have somebody who has an allergy to aspirin, it's called Ray's syndrome, then giving them aspirin would be contraindicated, something you're not supposed to do. So on the opposite hand, then, indications are things you are supposed to do. So with the ankle sprain, then things that would be indicated immediately post-injury, some ice, but also some range of motion, compression, elevation, those kinds of things. Those would be treatments that would be indicated at that point in time. Obviously, the coach has to communicate with all the other members of the sports medicine team. Now, obviously, the strength and conditioning coach isn't going to work super closely with the team physician, but they are going to work really closely with the athletic trainer, and oftentimes people like the dietitians or the sports psychologist. That's kind of how those things build on each other. Similar information in graphical form, because I like to include all the tables, so here's one of them. Terminology here, so closed kinetic chain versus open kinetic chain. So closed kinetic chain, you can see, is that the terminal joint, which is the hand or the foot, in closed kinetic chain, it's fixed to something stationary. So, sorry, I switched to the terminal joint. So the distal joint is stationary. So the distal joint here, so the foot or the hand, is fixed to something immovable. So in the case of a squat, your foot's fixed to the floor. In the case of a push-up, your hand's fixed to the floor. So both of those are closed kinetic chain exercises. As opposed to open kinetic chain, the foot is able to move relatively freely. So this is open kinetic chain. Another thing you'll see with open kinetic chain would be things like running is kind of a combination, as we'll talk about here in a second. In the case of upper body stuff, open kinetic chain would be like dumbbell presses, because you're holding the dumbbell, but the dumbbell can move in all three planes, and so that's an open kinetic chain. Your hand isn't fixed to anything. And so here sprinting is both. So it's closed kinetic chain when you're touching the ground. So in this case, her left leg is in closed kinetic chain. Her right leg is in open because her foot is swinging freely. So between the two, the question to ask yourself is the hand or the foot fixed to something immovable? If it is, that's closed kinetic chain. If it's not, it's open. Program design stuff. So they talk about this DAPRE program, which is pretty similar to the DeLorme program. It just adds an additional set, and then it doesn't use a 10 rep max, it uses a 1 rep max. So there's another little wrinkle there, but it is pretty similar to the DeLorme program. So basically what you do is you do 10 reps at half of what you estimate their 1 rep max to be. So if you estimate that they can lift 100 pounds, you have them do 10 reps at 50 pounds, 6 reps at 75 pounds, and then the third set is, okay, I think you can do 100 pounds. I think that's your 1 rep max. Let's see how many you can do. And so if they only get 0 to 2, which is weird to me because that means you accurately estimated their 1 RM, you have to take some weight off for the fourth set. If they get 5 to 6, you leave the same weight, and then they get as many reps as they can on the fourth set. And then if they get 7 to 10, you have to add some weight for the fourth set, and they do as many reps as they can. So basically it's a third set of, let's see how many you can do with this weight, and then we're going to go up or down for this fourth set, which is also going to be a, let's see how many you can do with this weight. So basically there's 2 sets 3 and 4, of doing a repetition max. So just do as many as you can, or burnout is another way to think about that with each of those 2 sets. So that's what this is. Aerobic and anaerobic training. Obviously you want to mimic the demands of the sport, but early in the rehab you start with just anything you can do to keep them active, and then we work our way into being more sport specific. Injury risk stuff. So here's a list of specific injury risk factors for the upper body, injury risk factors for the lower body, and then a handy little chart where they apply these principles that they've talked about in this chapter to rehabbing a patellofemoral injury. And that is it. So that's all of chapter 22. So then next time we'll move on to facility design, which is chapter 23. So we will see you then.